have two jobs. I'm here today as a national project lead based in the NHS Patient Safety Team with NHS Improvement for healthcare-acquired infections and AMR. But I also work in Bath and North East Somerset CCG as a commissioning pharmacist. And To Dip or Not to Dip is a improvement programme that originated in Bath and North East Somerset about 3 years ago, and I've been strongly associated with it ever since, and I feel like I've met most of the Infection Prevention Society membership, with the exception of, I think, the East, and I'm going there in May. So I'm sure a lot of you have already heard something about To Dip or Not to Dip, or have even adopted and are implementing it yourselves. So what we're really keen to do today is to share the learning, and it's really exciting that we've got a panel of people from different organisations who've implemented this in a different way and have met different challenges and problems and come up with very similar results and patient outcomes, which is actually really exciting from an improvement point of view, because it suggests that there are very many different ways of getting this to work. So this afternoon, this workshop is about shared learning to support effective implementation. And we're going to have a series of very short presentations, but we really want you to join in the conversation after that and share the learning you're bringing to the room, as well as asking questions. And I'm sorry that Twitter Bird has out-tweeted me, but I am at Beech if you want to tweet, and the hashtag, I'm sure you know it by now. So that's the reminder about Slido.com, and that's what it should be looking like on your phone. Anybody got connected out of curiosity to Slido.com? Anybody still struggling to try? Okay. So To Dip or Not to Dip is a quality improvement programme. It's a very systematic approach that originated in Bath and North East Somerset in the nursing home setting. And it was specifically designed to improve the way we manage UTIs. And it involves the education of health and social care workforce. But actually, I have to say, it's education of the GP workforce and the out-of-hours workforce, and in our case, to some extent, the microbiology lab workforce, as well as the care home workforce. And it's about how you can prevent UTIs, but how you primarily diagnose and manage a UTI appropriately. And it is based on the fact that we had found in Bath and North East Somerset, a large proportion of our care home residents were being inappropriately prescribed antibiotics for UTIs they didn't really have. What they did have was a positive urine dipstick. And if you're elderly, the chances of having a positive urine dipstick for nitrites is about 50%. So you might as well save your dipsticks and toss a coin. So it was around stopping use of urine dipsticks to diagnose UTI in older people, and actually starting to use clinical assessment, guideline, evidence-based clinical assessment. So it's around reducing inappropriate antibiotic use as a consequence of improving the diagnosis, but that doesn't mean stopping antibiotics necessarily. That might actually mean getting the right antibiotic for what might be an upper UTI, and the dipstick was driving a lower UTI diagnosis, a lower UTI treatment, and the patient was then ending up going on to get sepsis. We were very surprised to find we actually reduced our E. coli bloodstream infections, we think. Put it this way, they went down and they stopped going up at the same time we started doing this, and they stayed down, and we can't come up with any other idea why in Bath and North East Somerset. But I can't guarantee this is what it was. But it's around clinical teams, learning and adopting local guidelines, but implementing it effectively. It's around improving communication across the whole healthcare system, which is a sort of theme that's been coming out of today. But particularly around care homes and GPs about residents with suspected UTI. And the use of a clinical assessment tool, in this case an A4 sheet of paper, enabled very consistent, clear, systematic, same form, same data, same evidence-based diagnosis of UTI, and then that's faxed through to the GP practice, and they get used to having the same sort of information. And it's also around appropriate use of urine samples for culture and sensitivity testing. And this is around trying to improve the capture and use of urine cultures to inform individual patient care. And it's a particularly difficult group of people in care homes. I do acknowledge that, to capture urine samples. But the trouble is, the guidelines really do depend upon some local knowledge of what their previous UTI might have looked like. And if you haven't got that, then you need to go down a different pathway in terms of treatment. So it really matters. And it's not very sexy, but things like red top boric, boric acid tubes actually do make a difference when you're trying to capture a urine sample and make it last long enough to get to the lab. And these are the sorts of things that can get in the way of implementing an improvement programme. So, a reminder about why this might matter, if you needed one, is that UTIs obviously are accounting for about 50% of the E. coli bacteremias, and obviously 75% of those are perceived to be of community onset. And there's some concern that inappropriate use or inappropriate management of UTI in primary care is driving some of this. We'll wait to see what our local data capture looks like, but trimethoprim resistance in older people, particularly in care home settings, is really quite high. So it's really important that we manage the diagnosis and the treatment of their UTIs appropriately, irrespective of the gram-negative bloodstream infection agenda. So about a year ago, because there'd been so much interest in this, I actually set up a community of interest on Slack. If anybody isn't in that and would like to join that, you'll find it's stuffed full of people, experts, lots of resources, lots of sharing, and a brilliant opportunity to ask questions if you want to know something. You need to email me at that address, or if you know a colleague is in Slack, they can invite you because the permissions are set really low. It's not a secure environment. It is invitation only, but it's not a secure environment, so no patient identifiable data. But it's proved to be an absolutely brilliant way of rapidly sharing resources, presentations. Emma's nodding there because all her hydration resources are in Slack. And I'd strongly advise, if you're interested in this area, to join as fast as you can. We've got 300 plus people from all 4 UK nations and Australia and New Zealand to date so far. We've got psychiatrists in there, we've got older people's clinicians, we've got microbiologists, we've got infection prevention control, pharmacists, Public Health England, the lot. We've also got all of the fantastic resources, to dip or not to dip resources that Nottingham have produced, and these are all available from the Slack community of interest. And that's what they look like, and we'll hear a bit about those later, about what Nottingham did later. So I'm going to stop now, and I'm going to hand over to Mandy, all the speakers are going to introduce themselves, I'll do it far better than I will, and we're going to run with very short presentations from all the speakers, one after the other, and then take questions and discussion at the end. So I'm going to hand over to Mandy.
Hi there, so my name, excuse me, I'm full of cold myself, but hopefully you can hear me. My name's Mandy Slatter. I'm historically a hospital pharmacist, but I started doing some work for the CCG as a care homes pharmacist, and then out of that came this work to do with UTI diagnosis and treatment. Is it arrow down? Yeah. Okay, so as Elizabeth said, in our patient group, we implemented a training package. I think previously there'd been training in the background for the GPs, and it hadn't changed any of the data. So we decided to turn it the other way around and put in a detailed training package in the nursing home, straight to the nursing home staff, and see if we could find some change. We started originally with 8 nursing homes, but now we're up to all 23 on the patch, and plans to expand to residential, but we have some queries about whether the same format is going to work in the same way. We deliver this through our care home pharmacist team. There's 5 sessional pharmacists there, entering our 4th year, and it was originally funded through an improvement programme, but now it's an integrated part of the care home pharmacist work. So as I said, initially we had 8 nursing homes that we did a pre and post data capture and found some good results, but now we've moved on to a 3-monthly surveillance of around 750 residents. For those criteria there. It's a little bit busy, this slide, but to start off in the middle, initially our results were around, in these 8 nursing homes, showed that we sort of halved the proportion of residents who had an antibiotic for UTI, so that was down from 43 to 19%, so we're quite excited about that. But also within those patients who did receive an antibiotic, we had a 2/3 reduction in the actual number of prescriptions in those patients. And what we have found is that effect has been sustained. So if you look at top left now, we've switched now to 3-monthly data capture, and that takes us up to March last year. We've got a couple more to add in fairly soon, so if you join Slack, you'll see those once we add them in. And what you'll notice there is on the right, the blue is the number of residents with antibiotic treatment, and then the green line as a percentage. And we are down at around 12% there. But we have got that summer peak, which is something we need to think about what that's about. Is it due to dehydration? Another theory is it's around perhaps summer holidays and less staff, less giving residents drinks and things. On the top right, this is about, of those residents that prescribed antibiotics, how many actual antibiotics were prescribed because of people having multiple courses. So that takes you down to bottom left, and the number of courses per resident. And we're trying to shift that down, so if they do get a course, hopefully it's fewer courses within the time scale. Bottom right is our antibiotics we're using. We're trying to decrease that blue, decrease the trimethoprim usage. We're not doing as well as we'd like, but it is heading in the right direction at least. These couple of slides look at catheters. So we can see from the slide on the left that we've got the number of patients with catheters is the same. There's no seasonal change, but if you look at the graph on the right, you can see that we're getting more of those residents with catheters having UTIs, and then more prescriptions in those patients as well. So it mirrors the summer peak that we saw previously. In terms of successes, as Elizabeth stated, we found that there's no harm. We looked at admissions, AKI, urosepsis, and that certainly stayed the same, if not slightly went down, although the numbers are quite small. And that was really key for us in our first implementation, to ensure that we weren't ending up not treating patients and them going into hospital with sepsis. Engagement's been really good through the GPs, through the nursing homes, and through the CCG, who've really, really backed this. And use of the care home pharmacist team has been great as well, because it's developed those relationships between them and their nursing homes. It's very much been a multi-pronged approach, so I think Bay and CCG are probably sick of hearing about UTIs, because it came through every sort of format, the care home forum, the GP forum, through us training in the GP practices and also in the care homes. But I think that repetition of message has been really important. We've done a lot of data capture, so we have got evidence of our improvement, but also we've got a lot of detail. That's just a little brief overview of the data, but we can start to sort of dig down a bit deeper in terms of what's going on in terms of diagnosis. The information sharing has been great, because, as Elizabeth said, we started this off, and then Nottingham produced some fantastic resources which we now want to pinch back for our residential homes, because they seem far more appropriate for that group. Certainly the revisit, we went in a second time to the nursing homes, and we will keep going back with the message. That was useful in terms of not being a sort of helicopter thing that drops something in, says that's great and walks away, but we could feed back the results and say, you know, this is brilliant, you've done a really good job, you're not giving so many antibiotics, and look, everybody's okay. And then we could start building on the messages as well, and we introduced the AKI agenda and also information about hydration, so it's all kind of building on top of each other. In terms of challenges, staff changeover at the nursing homes, that's always difficult, so it's keeping the message alive, but we did produce materials that could get stuck up in treatment rooms, so hopefully the messages were passed on. Some of the bigger nursing home chains, if you like, were getting a different message or from their management, so we found we had to go up to the management to, you know, they were getting two different messages, they didn't know who to listen to, but we found that if you go and talk to the bosses there, they're usually pretty helpful. Elizabeth touched on multiple agencies. The labs weren't at first checking urinary samples unless they had a positive dipstick, which totally went against what we were saying. So there was a conversation with the labs in terms of changing their processes there. Going to the out-of-hours services, making sure that if the nursing home couldn't get the antibiotic from the GP, they weren't just going out of hours and getting it direct from there. And also so that the bladder and bowel service forms had something around dipsticking as well, so we had to look at that and see, make sure the message was consistent. A sustained focus, obviously, these people are receiving lots of different messages, and it's ensuring that your message stays up there. So that's a challenge at times. Elizabeth mentioned our diagnostic tool. I thought I produced a brilliant form. we haven't actually seen it faxed back to the GPs as much as we'd have liked, and we're trying to work out why that is. But we've still seen a change, and I think the nurses are probably still using the messages, so they're not calling the GP in the first place. But in terms of information that we get off the GP practice, the documentation isn't brilliant, and that's an area still for improvement. We've talked about choice, we're not quite there yet, but that's the next thing to work on. Data capture, it's been great, we've got a lot of data, but it is quite time consuming, and there's a bit of data capture fatigue, I think, among our group. So once we've really got over a year's information on this 3-monthly data set, we'll try and define it down to the real key areas. And also results feedback, I don't think that's been done as well as we could have done, but it's always good to have something to work on. So that's me.
Thanks, Wendy. So we're now going to ask Olu to come and share what they've done with To Dip or Not to Dip in Nottinghamshire, which is sort of scaling up.
Good afternoon, everyone. My name is Olu Ogunboide, and I'm the project manager for To Dip or Not to Dip in Nottinghamshire. So we worked with 5 CCGs, and Elizabeth mentioned earlier on that there was one of the CCGs in the city, and so they're now jumping on the bus now. So my slides are a bit busy because we're working with 5 CCGs, and I'll be sharing information on all of them. So we started the first pilot in the Nottingham West. So I worked with a project lead who was a consultant microbiologist. So I'm not clinical. So I worked with 6 months with the project lead. So we started with the first pilot in Nottingham West with 2 GP practices and 6 care homes. So in terms of data collection, so it was the pharmacists who assisted in collecting data. And so we were relying on the availability and capacity of the pharmacists to collect data, which is quite important and key in any quality improvement program or project. And so collected baseline data for a year. We decided to do the same period so that we wouldn't miss out probably the winter period, the summertime. So we collected baseline data for a year, and we carried a 3-month pilot. So in the Nottingham West, we did the 3-month pilot and rolled it out straight away to all the other care homes and GP practices. And then we moved on to the Mansfield and Ashfield in March. So the project was delivered by me. At that time, the project lead had to go back on clinicals, so I led the project after having clinical input from her and my infection control lead. And so data was collected by the care home pharmacists and then was evaluated by myself and the project lead. And we also collected a year baseline data. And so we've rolled it out to all the other care homes in that area. Similar to Nottingham North and East, with that, it was led by the care home pharmacist. So I drew back a little, and then the care home pharmacist led the project in that area. So they did a whole locality. It was a bigger team. So it was 7 GP practices and 9 care homes. So in the Newark and Sherwood area, due to capacity issues of the pharmacists, we only started the pilot there in December. But then we're not waiting for the 3-month pilot to now roll it out because we've had successes from the other areas. So we were rolling out straight away. We just collected data just to show that there's going to be some improvements in that area. So the project was funded by Public Health Nottinghamshire County Council, and I've got Nottingham City there. So the project was initially for those 5 CCGs, and then Nottingham City are now hoping to start the project now because I think they're the only ones left out in Nottinghamshire. So it's a bit busy, like I mentioned earlier on. So that's the data from the 3-month pilot we did in the first 3 CCGs. So the Nottingham West. The second column there, you can see the number of residents. So we compared the data for the pilot period to the previous year. And so we're comparing like for the same months. And then we saw a reduction, 24% reduction in number of residents prescribed antibiotics for UTI. In the Mansfield and Ashfield area, about 68% reduction. And then in the Nottingham North and East, about 62% reduction. And you can see in the number of antibiotics prescribed as well, there's a reduction there. So 44% for Nottingham West, Mansfield and Ashfield about 71% reduction, and then NNE about 63% reduction. We also looked at those on long-term antibiotics. So in the Nottingham West area, they had started doing some work prior to the project starting. And so they were not, they didn't have many residents with on long-term antibiotics because the pharmacist was already working on there. In the Mansfield and Ashfield, there were 2 different residents admitted at admitted at the care homes at 2 different times. And so, and this, with the project and with the pharmacists collecting the data, it helps them to be able to highlight which residents needs a medication review. And in terms of those on long-term as well, we found that on long-term antibiotics, no samples have been sent of, and they're even resistant to the antibiotics they are on. And so it helps when the pharmacists collect data, they can be able to carry out medication review as often as possible. And then the NNE, that's the one that was led by the pharmacist. So there was 100% reduction in long-term antibiotics. And so we've got data, the second section, so that's data as at till to date. So for Nottingham West, so we have 12 months of data. You can see we're still reducing the number of residents with UTI. So that's about 23% reduction there. For those on the prescriptions, about 45% reduction. So we're still reducing it, and that shows the viability of the project, really. And then in the Mansfield and Ashfield area, same reduction, 77% reduction in number of antibiotics prescribed, and about 69% reduction in number of residents prescribed antibiotics for UTI. And similar in the NNE, so about 62% reduction in number of residents with 1 or more antibiotics, 64% reduction. So that they've done the pilot for 3 months, and then we have 3 months post-pilot in that area. So we're seeing the reduction, which is good. So it's still busy as well. Thought to share the graphs because when you're speaking to GPs, it's not just going to speak to them about the project, but taking data along with you is very, very important. And so anytime I'm going to a GP practice for a practice meeting, I ensure I have my data to share with them. So you can see it there, black and white. So that's the graph there showing the reduction. You can see where we started the pilot, and then we've seen a reduction over time. Just like Mandy mentioned earlier on, we see a summer peak as well. It's evident in the graph. And so the second graph on the right is the number of antibiotics prescribed. So it's comparing it to the previous year. And you can see for 2017, there's been a reduction compared to the previous year in the various months. Same as Mansfield and Ashfield. So we started the pilot there in March, and you can see we've seen a reduction, and that summer peak is evident there as well. And of course, in the antibiotics prescribed compared to the previous months. So you can see the reduction. Then NNE, I've got NNE data as well. Similar there, we started the pilot there around July, and you can see the graph gradually is coming down. And of course, in terms of the data as well, we've seen a reduction. When Bath did the To Deep or Not To Deep project, as one of the advantages they found was a reduction in emergency admissions. Whether it was related, we don't know, but they found a reduction. So we started looking at emergency admissions right from the beginning of the project. And so we can see, so the admissions data there is for all the care homes. So we didn't put specifically the pilot care homes, for all the care homes. Despite that, the blue line is for all emergency admissions, and then the green line is for emergency admissions for UTI, AKI, and dehydration. And you can see the graph is there. We're maintaining it. So it's not going up, which is what we want. We don't want it to increase. We want it to maintain or as well as reduce it. And similar in the NNE data as well. The red line is primary diagnosis, and then the green line is for secondary diagnosis. So looking at this primary diagnosis, you can see the reduction, and of course that summer peak there as well. It went up a little bit. So we're maintaining that. And then this line is extremely busy. but I felt that I needed to include the challenges and the solution we found to it, especially for CCGs or areas you are planning to implement the project. So the challenges we found along the way, and then what we did to ensure that we overcame those challenges. So the outcomes we had, so reduction in antibiotics prescribed for UTI, reduction in number of residents prescribed antibiotics for UTI, dipstick testing reduced dramatically in the care homes, and I think one of the problems that which we came along was not just the care home staff, it's healthcare professionals, doctors, community matrons, district nurses, and we expect that we'll know better. It's there in the national guidelines, and we should all be following the national guidelines. And so I think the good work that Elizabeth has done, we need to ensure that it's not just Elizabeth, it's not just those who are implementing the project, it should be all of us singing the same song. And then also telephone calls from care homes to GP practices. The practices are happy because we've seen a reduction in there. With the assessment tool, that communication is helped with the communication between the care homes and the GP practice and reduce the calls. And then we've seen no increase in admissions for UKI and AKI, as mentioned earlier on. So we've seen an increase in the urine sample sent for culture, which wasn't being carried out, and the importance, and because I deliver training as well to the care homes, and when I'm talking about the samples, that's one of the main reasons why we can confirm whether a resident has a UTI or not, based on the samples that is sent, and so the importance of that. So we've seen an increase in that area. Face-to-face assessments of the care home residents. So rather it was just a phone call to the GP practice. We've done a positive dipstick test, can we have antibiotics? Now the GPs are thinking, better, and then also there's a lot of face-to-face assessment of the residents. And then, of course, there's increased communication between the care homes and GP practices. And in Nottinghamshire County, so we've trained 990 staff. I think it's a lot more now because I've delivered some training since I sent the presentation in about 137 care homes, which is quite, I'm quite happy about, really. So the challenges we found, so 2 minutes more, okay. Non-engagement of care home managers and GPs. So we had quite a number of care home managers who were not getting engaged, and what I did was attend care home forums, send communications, and of course reports as well, share reports with them. High turnover of care home staff, because you deliver training to a set of staff today, and then by the next couple of months, they're no more there, they have new members of staff. So what we've done in Nottinghamshire is that we have electronic resources which we send to the care home managers to share, and we have resources which we leave with the care homes when we do the training. And then there's also an electronic library of resources as well, which we can prescribe to the care home managers. And then in terms of capacity of the primary care pharmacies, and that was why we're not able to commence some pilots earlier on as we expected to. So some areas, they decided to use the technician, so you can use a pharmacy technician to collect data as well, so it doesn't necessarily have to be a pharmacist. And then uploading the assessment tool onto the GP's clinical systems. We found out that because when we collect the pilot data or post-pilot data, we didn't find so many assessment tools recorded onto the GP clinical systems. And so what we did was we have a training handbook which was developed. So we give that when I attend the practice meetings for the receptionist, because I think it stops with the receptionist. So if the receptionist is not uploading it, then we wouldn't find it there. So they have a training handbook to help them to understand the pathway. Changing practice of external providers. So we work with the community providers, closely with them, to ensure that they understand what's happening in the care homes and communicate effectively with them. Care home outbreaks affected our training sessions. So many training sessions that had to be cancelled. So we work closely with the infection control team to ensure that we don't go into the care homes when they have an outbreak. And then some GPs not following the national and local guidelines for prescribing antibiotics. So circulating and promoting the antibiotic guidelines, attend PLT sessions, practice meetings to promote that. Culture change for healthcare professionals. Ooh, my time is up. Okay, should I just quickly round up? I just have one more point. And then sustainability of the project. So we can So provision of ongoing training and then the use of the community providers to provide, to continue providing the training. And then, of course, I'm working with the infection control team.
Thank you, Anna. We're uploading all of these presentations that are already in. Most of them are already in the Slack community of interest. So you can access all this fantastic learning through that. There's definitely some themes coming out of here. So we're going to move on to Cornwall and Louisa, who's a drug bug nurse and tweets as drug bug nurse.
Hi, sorry, I've got a bit of a cold as well. This will be a good test of our infection prevention today with all this illness about. So, hi, thanks for having me along this afternoon and inviting me, Elizabeth. My name's Louisa and I work in Cornwall on a nurse-led project titled the Drug and Bug Project. And this was funded initially just for a year from Health Education England to raise awareness across the spectrum of professionals and members of the public about antimicrobial resistance. It was the first of its kind, a kind of nurse-led project of this nature, quite challenging to kind of set some clear objectives within that year and have something that we could take away as hopefully getting us continuous funding. And it was part of Cornwall's 5-year strategy for improving antimicrobial resistance. So the Cornwall Antimicrobial Resistance Group is something some of you may have heard of. That's another action from that 5-year strategy, which we're very proud of. And I think today is kind of the essence of that, with microbiologists, nurses, doctors, all coming together and sort of worrying about infection prevention and control. And the sort of initial panel this morning where we had that sort of multi-professional team up there was fantastic. And that's multi-organisational as well. So I'm now employed, we've got substantive funding, I'm employed by the Royal Cornwall Hospital Trust, but I work mostly out in the community. So that's kind of meeting the challenges of STP, working across boundaries and across professions. Part of that first year's objective was to introduce the to dip or not to dip UTI management tool into care homes. And thankfully we had Elizabeth Beech's inspiration to do that with. And our tool is very similar to hers. We shared, they kindly shared all their work with us, and it was really helpful to have that inspiration. Similarly to what the other speakers have said, our objectives really were to bring practice in line with cyanotic guidance. So we knew from audits done nationally and in our own primary and secondary care that we felt that about 75% of diagnosed UTIs actually weren't UTIs at all. So we had quite conclusive evidence that they were being over-prescribed. We also wanted to make care home staff feel more confident when talking to relatives and doctors. So this is kind of an aid for them, an evidence-based approach that would give them confidence. And I think that we carers do find a lot of pressure from relatives to prescribe antibiotics, saying, we know what's wrong with them, they've got a UTI, we've put them on antibiotics, is a much easier answer than saying, actually, we're not quite sure what is wrong with them. Elderly medicine is very challenging. We're going to watch and wait. At this time, we don't think it's a UTI. That's a much harder answer if you're a carer or a registered nurse equally. As Ollie mentioned, that GP conversation, a lot of GPs aren't able to visit these patients and residents to do face-to-face reviews, so a lot of it's done over the telephone. So this tool we hoped would kind of speed up that process. And we linked it with an education package. So we have 235 care homes in Cornwall, but we've already been to 80 of them and delivered an hour's teaching session which covers antimicrobial resistance, infection prevention and control, so catheter care, continence, hydration, IPAC, and UTI. So learning the basics, going back to basics, what are the signs and symptoms of a UTI? And why is it best not to dip urine? Elizabeth mentioned there's sort of 50% of asymptomatic bacteria. So that all lumped together in just an hour's teaching session we found really effective. So our results very almost coincidentally mirror the other sites across the country. So we went from 23 patients. I should mention that this was a very small pilot. So we only did this in 4. This was due to time constraints, so we only had a year. So we had a 4-month period with 4 nursing homes. It was a short period and a small number of nursing homes involved. But our numbers were still mirrored the other sites. So we had 23 patients pre-intervention intervention who had UTIs, and that went down to only 8. So again, a sort of 66 relative reduction. And in terms of prophylactic antibiotics, after people were reviewed on prophylactic antibiotics due to the intervention, we nearly everyone went off them. So that was really interesting. And this was, I did some work with Dr. Pollard, who's part of our innovation team, and he kind of put this into cost modelling, found that we saved just in that short period £3,700. That's almost £1,000 per nursing home. Most of that was on carers' time and GP time, so it's a really good seller for GPs and carers alike. Loads of time is spent on diagnosing UTIs. And cost modelling that, extrapolating that data out to the whole of Cornwall in care homes, we worked out we would have a potential cost saving of £500,000. So what this has sparked, obviously sharing work locally and nationally was kind of how this all began anyway. That's the organic thing about it. So we've continued to do that. We, as a team, the drug and bug nurses, got to the finals of the the Nursing Times Awards, and this work has actually been published at the end of last year as well. We found that it's motivated our secondary care, so our acute setting, to implement a no-dip kind of quality improvement project as well, and that's been really successful. They've had an almost 70% reduction in UTIs diagnosed from MAU and ED, from sort of education and reducing the amount of dipsticks that we're using in that setting. And obviously from the cost savings and all the evidence that we've got nationally, the GPs made a unanimous decision that they would like this to be rolled out county-wide, which was fantastic, and that sort of came at the same time as us receiving substantive funding. And it was added to our care home standards. So our CCG, our acute setting, and the Primary Healthcare Trust have all kind of collaborated and agreed that this is a really good project to support. And our biggest challenge now is how we do that. And there's 235 care homes in Cornwall. There's just one of me. How do you keep that momentum going? How do you give that education out to all of those homes in an effective and continuous way where you're going to have a positive outcome that's measurable? So what we've started to do is a road show, which is an education package, 3 hours, titled Leaking the News, and that really kind of brings together all of the learning in terms of UTIs, preventing infections through catheter care, continence care, really basic, going back to basics and getting them right, hopefully, and trying to inspire carers and nurses from a variety of settings that those things really do make a difference, not just to individuals in terms of what we found from patient outcomes, but also to extrapolating that to the bigger picture of the global crisis that AMR presents. So those carers in those nursing homes, by washing their hands and not letting a catheter fall on the floor, can actually be having a big effect on the global health challenge of antimicrobial resistance. And this sort of systematic approach to diagnosing conditions has been really qualitatively fed back to us that would be useful for other conditions as well. So things like surgical wound infections, chest infections, pressure ulcer, risk assessing those. So we're really hoping that this will snowball into other conditions and that we can use a similar tool. My fear as a nurse that introducing another tool would just be the bane of everyone's lives, but they really supported it, and a lot of our qualitative feedback in interviews was that they wanted more tools of this nature to support them and give them confidence. So I'm working with the consultant nurses in tissue viability at the moment to do that. And my sort of final statement in yellow there, I just want to, that's kind of the essence of the Bug and Drug project and my feeling as a nurse, and I think what we're all trying to achieve now, which is that empowering carers and nurses in various settings to make the link between basic nursing care, not only to achieve measurable improvement in patient outcomes, but also the wider global health challenge that AMR presents. I think that we've all proved along this panel that that really does work, and as a nurse in a kind of hectic healthcare system, if you know that you are empowered to kind of make small differences, and that does have a positive effect, that's really helpful.
Brilliant. thank you. Right, we're trying to stay on our time as well. Just to let those of you know using Slido, I've changed the poll. So some people have clocked that and they've done the next poll. But if you are a Slido user, there's a second poll. I'm going to move on to Michelle, who works in Bristol.
Good afternoon, everyone. I'm Michelle Jones, and I work at Bristol CCG. I've been working there for about 2 years now as a medicines management pharmacist. So, following the success of the To Dip or Not to Dip project in Baines, we thought that we'd like to do something similar in Bristol, but we used a slightly different model. So we have medicines optimisation pharmacists, which work in all our GP practices that are employed by the CCG. So we used our medicines optimisation pharmacists to deliver the training package to both the nursing home staff and also the GP staff as well. For our documentation and the educational training package, Elizabeth and her team and Mandy were very kind and shared what they had done, so we used that. We also worked with one of our GPs, Dr. Stephen Granier, who's also the RCGP lead for AMR, to help develop and structure the training. We also, at the same time, updated our primary care antimicrobial guidelines, so they were in line with national guidance, and also produced some training kind of A4 diagnostic sheets for our care home staff as well, to kind of support the work that we were doing with them. All of our resources are available on our website, which is the BNSSG formulary website, which is the Bristol, North Somerset and South Gloss formulary website. For the monitoring and evaluation, our medicines optimisation pharmacists did this remotely using EMIS, which is the GP computer system that we use within Bristol. We did monitor for unintended harms as well, following on from what they've done in Baines, and the data collection was done prior to the training being rolled out to our nursing homes, and then once the training had been rolled out to our nursing homes. So our results were similar to across the panel, so we did see some good reductions in antibiotic prescribing for UTIs. So at the top line, you can see the number of residents prescribed one or more acute courses of antibiotics as a proportion of all our residents. And this showed a 10% absolute reduction in proportion of residents prescribed an antibiotic. And then on the second line, you can see the number of acute courses of antibiotic prescriptions over all residents prescribed an acute course of antibiotics. So the number of actual prescriptions over the number of patients prescribed an antibiotic. And we had 183 fewer antibiotic prescriptions. That's around a 66% reduction. And we also saw around a 53% reduction in the number of residents that were prescribed an antibiotic. I should also say that the time period in which we collected the data was over a 6-month time period, and we did ensure that it was the same 6-month time period to ensure that there was no seasonal variation with antibiotics. We have 39 care homes in Bristol. Due to our MOP capacity at the time, we delivered the training to 33 of our care homes. So looking at the antibiotic choices that were made, so this is the antibiotics that were prescribed and the different choices. So the left-hand side is before the intervention and the right-hand side is after the intervention. And we can see that we have had a reduction in our trimethoprim prescribing and a slight increase in the nitrofurantoin prescribing as well there. And then looking at some of our challenges and successes. So when we were delivering the training, one of the common themes that came out were concerns over patients who couldn't verbalise their symptoms, especially patients with dementia. Nurses like to be able to have a tool that they could use, so using a urinalysis to be able to exclude a UTI. But I think it was just explaining to them the evidence behind the fact that even if you did get a positive result, then there's a 50% chance that would not, it's like tossing a coin, there's around a 50% chance that still wouldn't mean that the patient has a UTI. So I think just explaining the evidence behind that helps elude some of those fears. And also having a diagnostic tool as well meant that they could keep an eye on their patients, watch for waiting, and they could actually go through all the symptoms and signs that the patient did have. Another challenge was around the EMIS coding. Because we were doing our data collection via the GP computer system, if the UTIs weren't coded correctly, then this may have meant that they weren't picked up. However, this was the same for pre- and post-intervention data, so that should have evened out for both sides. We did have, with our medicines optimisation pharmacists and their capacity, so we weren't able to deliver the training in all our nursing homes. However, following on from the success of this project and following on from other work that our medicines optimisation pharmacists have been doing with our care homes, we are currently putting in a bid for specific care home pharmacists so that hopefully we can, one, help sustain this project and make sure that we're continuing to collect the data and continuing to train new nurses that are coming into our nursing homes as well. We did have some challenges initially around pivmecillinam sensitivities. So this is included within our guidelines, but at the time when it was included, our labs weren't plating pivmecillinam. This has since changed. Our microbiologists were really positive and really encouraging as well, and worked really hard to make sure that that could be included in the plate as well. Some of the successes were that it utilised our current workforce, so there was no additional funding required at the point when we were doing this pilot, and we did see an overall reduction in acute antibiotic prescribing for our UTIs as well. The GPs appreciated the training, and our nursing home staff really appreciated the training as well. We did do a doodle poll following the training, and that did show around 80% of the nurses that had received this training found it extremely useful. Thank you.
You can see there are some themes coming out of this, aren't they? And I promise you we didn't prepare this. Right, we are pushed for time. So David is now going to come and talk about East and North Hertfordshire. No pressure to go fast, David.
You told me 3 slides, 5 minutes.
I did. You're
So-
a very compliant member of the team.
So here we go, 5 minutes.
Sorry.
Okay, I'm a pharmacist at East and North Hart CCG. I've been in post approximately a year and a half. And I'm sort of, I feel a bit like I'm on a, sort of admitting to things that, almost like a confession, but a lot of this is borrowed work. I make no apology for it. I've taken a lot of credit locally for the work of others, so I'm very grateful to the likes of Elizabeth and Dr. Joseph for giving me all the work that they have. Just to set the scene, so East and North Herts consists of 62 older people's care homes and provides over 3,400 beds. 25 of those are nursing homes. And as I'll explain, we had a kind of multidisciplinary approach to adopting and rolling out to dip or not to dip within East and North Herts. I should say that we're sort of earlier on in the to dip or not to dip journey. So it was this time last year at this exact meeting that I met with Elizabeth and Dr. Joseph and was encouraged to develop it locally. So really what I'm going to do rather than present results is talk about how we implemented it within the CCG. What we did was we used existing educational structures that exist within the CCG to deliver the training. So there are 3 different forums by which we educated the GP-based staff. So we have link infection control nurses. Those are each GP practice has an infection control nurse. They have regular training events, so we develop the training at those. They're practice nurse forum events. Every GP practice within the CCG attends the practice nurse forum. And then finally, to capture the GPs themselves, there are locality events which are attended by all clinical staff, in theory, of all the GPs within a particular locality. So what we have is a kind of belt and braces approach to educating the clinical staff within the GP practices. In theory, the nurses were asked to educate all the clinical staff within their GP practice, and then almost to mop it all up to make sure that everybody was educated. We delivered the training within the locality events. Then finally, we're very fortunate in Hertfordshire to have a very active care providers association. So it's known as the Hertfordshire Care Providers Association, which is supported by the County Council. That organisation is voluntary for the for the care homes to be members of, but it's kind of the more the care homes give, the more they get out. So what we find is that there's very good, robust structure for education. So the Hearts Care Providers Association developed an educational package, 5 of which were issued to various care homes on a voluntary basis to attend. So really what we try to do is educate all the clinical staff within the GP practices, and then finally educate all the care home staff via the HCPA. That's the theory. So how do we deliver, and what are the results of what we did? So as I said before, I owe lots of gratitude to Elizabeth and Dr. Joseph, and as is mentioned already, Slack is an incredible resource. So people have been extremely generous in sharing their work, and I've taken a lot of credit. I kind of feel a bit guilty for the credit that I've taken, but some of the resources literally can be adopted straight from the likes of Nottingham and have been adopted within East and North Hertfordshire. How we delivered the programme, if you like, was to get together all the key stakeholders. So we had a working group. A project manager, as we've seen here, was integral to the success of the programme, and they really kept everything running smoothly. Various other people, pretty obvious, microbiologists, nursing quality managers, head of IPC, the representative from the Hearts Care Providers Association, which, from what I understand, we're very lucky to have a very active group which really helped to engage with the care homes themselves. We had a GP representative, medical director, head of quality improvement, etc., etc. I've been really fortunate in that the senior management team within the CCG have been very supportive of to dip or not to dip. So after this event last year, I shared some of the data from the Baines project, and really what they wanted to do was go in with a sort of big bang approach and just adopt it across the whole of East and North Hertfordshire, and that really helped drive to dip or not to dip. There's also very good support from the senior management team within the CCG, so the governing body of the CCG itself. In terms of delivery, we just piloted to dip or not to dip in one single care home. So we used the resources on Slack and from other successful projects and adopted them very slightly, making sort of slight tweaks to the programme, and piloted it in one care home. And the results, as Elizabeth has suggested, are very similar to what other successful projects have seen. So, as I say, it's quite embryonic in delivery, but this is a single 61-bedded care home which implemented to dip or not to dip in July 2017, and we collected data for 7 months and found a 78% reduction in antibiotic items prescribed for urinary tract infections. How am I doing for time? Okay, last slide. Finally, what I was asked to do is just go through the challenges, successes or otherwise. So the colour's not come out. I've tried to show what's worked well, what's worked less well. Essentially, they fall under 4 main themes. So delivery of training. One problem that we found is that those care homes that are tend to turn up to the training events, or the staff that turn up to the training events tend to be what I would call self-selecting. So the very, in inverted commas, good homes tend to turn up to the training, whereas those that are more troublesome, if you like, or difficult to engage with tend to not come, and they're the ones that you could probably benefit from most. We have some very good GP advocates, real champions that really, they just get told once and they disappear off and sort of advocate for to dip or not to dip. The thing that I should say is that we're fortunate in Hertfordshire in that we're a vanguard site for care homes, and what that means is that the service for the care homes is delivered. Every care home has one single GP practice aligned to that care home. So if you want to implement a change, you just have to go to one GP practice and one care home, and in theory that can be implemented, which has made the implementation theoretically a lot simpler. There's been real enthusiasm for the project. I've almost had to keep everything down. I wanted to introduce it quite slowly, and I was basically asked to go big and wide, and so as of October 2017, all care homes in East and North Herts, in theory, are running with to dip or not to dip. Measuring outcomes, I've had a slight problem with collecting some data with measuring outcomes, so I'd be grateful for any advice on that. Pharmacy prescription data is very easy, but some of the clinical coding is really quite an issue, and obviously the concern from the medical director and other people is, are there any unintended adverse consequences? I'd also like to show if there are any positive consequences. So if we're seeing very big reductions in antibiotic prescribing, there's a real concern that there could be something unintended and negative going on, so we're trying to collect that clinical admission data. Finally, with regard to communication, I owe a lot of gratitude to the project manager. They kept everything running very smoothly, really what we did was we used a lot of resources that other people had developed, and again I owe a lot of gratitude to them. Finally, good and bad, we had very good engagement and feedback from stakeholders to the extent where you almost want them to stop, because you keep changing your forms or giving more information, and ultimately it gets quite confusing at the end. So it's good and bad about some of the feedback that you get, but it's quite nice that people are really engaged, and I was pleasantly surprised about the care home staff that really seemed to take it all on board, and I was grateful for that. And finally, learning from others. So as I said before, Slack's been really good, and I've found the likes of Elizabeth very approachable, and I do owe you big time. So that's why I'm here today, because I don't really like doing presentations, but here I am. So thank you.
I think I should just point out where they've said Elizabeth, please replicate that with Baines CCG Care Home Pharmacy Service, because they've actually done the work, and I've just shouted a lot about it. Thank you very much. Really fantastic presentations, and all different approaches of implementation, which is what we wanted to share with you, but really similar outcomes, and I think that's really interesting. I was making notes because there are some really good ideas in there that I think we might want to adopt back in Baines. So I guess there's something around sharing learning and making that really accessible is very helpful. But I did want to let you know, before I open up to some floor questions, very quickly, NHS England fund pharmacists in GP practices under the GP Practice Pilot Scheme, and they've just launched their call for pharmacists in care homes. So there will be pharmacists out there in some of your localities that you might not know about, that might be a useful resource if you were thinking of trying to adopt to dip or not to dip with a pharmacist model, if you don't have your own access to pharmacists. Obviously, Cornwall have not used pharmacists, but one of the themes that came across was there was quite a lot of pharmacist involvement, and I'm conscious that not everyone will have access to pharmacists in that way. Right, and before I ask for questions, there was one question particularly on Slido that came through about Public Health England, and that's very helpful, thank you. Public Health England are currently updating their UTI diagnostic flowchart. You know, the HBA flowchart that's been around for ages? That has been completely shredded, it's been revamped. Scotland and Sign are in the game as well. It's going to incorporate sepsis and early warning scores as well. And we're going to try and make it very, very clear that for older people, you do not use a urine dipstick in blazy, shouty letters, but also to align with the sepsis agenda. That has been through 2 stakeholder engagement events, and I'm expecting that should be available in the next 2 months. NICE are currently reviewing the management of UTI, but not the diagnosis of UTI, and they will have NICE Common Infections guidance published at around December time. So there will be guidance coming out on recurrent UTI, for example. And the last thing is that Public Health England are also putting together a UTI leaflet for older people. And I think that might help with some of the engagement with the families and the patients' carers around what is a UTI and why we're worried about resistance and what you can do for self-care and why having an antibiotic might not be in your best interest.